My dear friends, let us see how we can perform a safe and effective direct chop in a big black cataract, and in this particular case also associated with a poorly dilating pupil. At the outset, let me reiterate that it is always important to dilate this pupil, even though it looks to be about 5 millimeters, with a pupil dilating device, because you can be sure that this pupil is going to shut down on you as you proceed with phacoemulsification, and also in order to improve the visibility of the capsular rex's edge and the fragments while you go about performing the phacoemulsification. So I make an additional side port in order to implant my pupil dilating device and put it into place. This is a ring which has 4 scrolls similar to the Malegend ring. It's called the Gupta ring. And the trick of engaging this Gupta ring is that in a scroll there is the upper loop and an inferior loop. All you have to do is to make sure that the inferior loop is tucked across the pupillary edge. It's quite simple because unlike the Malegend ring, in this ring the scrolls are pretty wide open and it's quite easy to tuck it, at least the first 3 loops, astride the pupillary edge. As you can see. And while implanting the 4th scroll, again you flex it, bring it to the pupillary edge and simply tap it into place using an iris depositor. This does the job. So this is the first and important step when you have a hard cataract and a pupil that's not dilating too well. Now what you see is a pretty black cataract. The anterior capsule shows subcapsular fibrotic areas. So the initial plan is to perform a large size capsular rexus, at least 5.5 millimeters or ideally 5.75 millimeters. This large capsular rexus will enable you to mobilize the fragments in a much more easy fashion. So take your time in creating the capsular rexus. Make sure that you get the adequate size of capsular rexus, because a small capsular rexus will completely frustrate your attempts at performing phaco in this case. So I think this capsular rexus is about 5.75 millimeters. I'm quite happy with it. The hydrodissection also has to be very good. Small amounts of fluid injected at multiple locations, because there isn't much of cortex in these cases, and that is why the cortical cleavage hydrodissection is actually very simple and easy to perform, and the amount of fluid required is also very less to achieve cortical cleavage hydrodissection. Now when we come to phacoemulsification, you need the right tools for the right job, and the first thing is to fill up the anterior chamber with a dispersive viscoelastic. In this case I'm using Viscoat, which is a combination of chondroitin sulfate and sodium hyaluronate. I use a long tip chopper. This is a 1.75 millimeter sharp tip chopper, and I'm using phaco tip, which is a microflow tip with a 30-degree bevel. I bury the phaco tip, and then using the sharp chopper I initiate the crack, and I'm able to, with the help of my paddle maneuver, separate this piece so that the base plate cracks open. Now what I want you to realize is the amount of cavitational energy that is used. So only a minuscule amount of cavitational energy is used to drive the tip into the nucleus. The subsequent breaking up of the nucleus, deepening the crack and separating the fragment, is brought about by 2 forces. One is vacuum that holds the piece onto the phaco tip, and the other is a mechanical force which simply is generated by the sharp tip chopper. So the vacuum and the mechanical forces are the ones that are primarily acting when you do the direct chop. You are not using cavitational energy, and up till now the amount of cavitational energy used is pretty minuscule. and so far you are totally endothelium safe. So bury the phaco tip and take the sharp chopper, flex it and then gently separate it, and you find that you're able to create the separation of the blaze plate as well. The second important point to note is that you have to break it down into many pieces, at least 7 to 8 pieces. The total number of smaller fragments that you end up with is going to make sure that the fragment removal and the mobilization is going to be much more easy. Now remember the most important caveat, that the most amount of cavitational energy that you're going to use is not during the cracking of the nucleus, but in the mobilization and eating up of the fragment. This is where the cavitational energy is going to be consumed, because the nucleus has a very large bulk and you need to use cavitational energy to eat this up. So in order to minimize cavitational damage to the corneal endothelium, you can adopt two techniques. One is, do not give phaco power till the tip is occluded, because the nucleus fragment will now absorb the phaco energy and prevent the dissipation of the energy to the corneal endothelium. The second important thing is to always bring the fragment to the center, which is called the safe zone, where the corneal endothelium is far away from the phaco probe, and then apply the energy. I prefer the multi-burst mode because you can control the amount of cavitational energy that is delivered while removing the fragments. The third important thing that you have to remember is to make sure that the chamber is filled up with your dispersive viscoelastic. The dispersive viscoelastic will go and get stuck to the corneal endothelium and will help to protect it. Even if you have fragments flying around or shrapnel flying around and it hits the endothelium by mistake, the dispersive viscoelastic will coat and protect it. So take your time, be patient, and slowly carry out each and every step of the procedure. So you see that this was a very hard cataract, and with the judicious use of phaco power, I have greatly minimized cavitational energy that is released within the anterior chamber. This is the end of the case, and the reason why I am not trying to remove those little bit of epinuclear fragments is because I need to give power, and that would mean unnecessary cavitational energy released into the eye. And that is why I simply float out these pieces with viscoelastic itself. So that's it. The entire procedure is done. It looks pretty safe, it looks quite simple, and even though it was a rock hard cataract, using the right instrumentation, the right technique, and a proper strategy in the management, you can end up with crystal clear corneas on the first post-operative day. The cortical aspiration is done. This patient was operated in a center that did not have a slit lamp photograph system, and therefore I am not able to provide the post-op photograph of this patient, but this patient had a clear cornea with very mild striate keratopathy close to the incision. So once the cortex is washed off, the hydrophilic acrylic lens or whatever foldable intraocular lens that your patient desires is implanted within the capsular bag. Make sure that the injection of the IOL is done smoothly and that you do not have to employ too many manipulations to get it into the bag. And then comes the process of washing out the dispersive viscoelastic. This is done in a very careful fashion. The bag has to be completely emptied. If there's residual viscoelastic within the bag, it can lead to a condition known as capsular block syndrome. Now is the time to remove the pupil dilating device, the Gupta ring, and I use an intraocular forceps. I think it's one of the best ways. So you catch the strut, you pull it, and then you just retract the iris a bit, and the scrolls just slip out of the pupillary edge. In the case of the superior strut, I just pull it down with my Sinskey hook. I detach it from the pupillary edge, and it's quite easily removed without creating any damage to the endothelium. The last point I want to say is, before you embark on handling hard cataracts, it's absolutely important that you perform specular microscopy. If the endothelial cell count is less than 1500, or if you have hexagonality which is less than 50%, then do not use phacoemulsification in these compromised eyes. So I wish you all the best, and I hope that you can perform phacoemulsification successfully, safely and effectively in hard cataracts just like this. I thank you for your attention.